Okay. I've been helping patients quit smoking for more than 15 years through the provision of quit smoking clinic, which we first established in USM and now at IIUM. What I can say in general is that we have to individualize our treatment or interventions, incorporating both behavioral and also pharmacological interventions. So my experience is that we have to do the 5 A's from asking, advising, assessing, assisting, and also arranging follow-up. The bulk of the work is actually under assisting, because we want to ensure that we choose the best treatment or interventions, particularly pharmacological, using the criteria safety, efficacy, suitability, and cost. Because we know that no two smokers are really the same, although they may be smoking the same brand and same number of cigarettes and so on. But when it comes to helping them to quit, my experience is that we really have to individualize, because a person who's smoking 20 cigarettes per day would require, for example, higher dose of NRT in combination with varenicline sometimes, or 2 types of NRTs, and then also helping them to incorporate the behavior intervention based on their occupation, family support, and other criteria. Okay, for personalized intervention, I mentioned that when we do the 5 A's, after we ask advice, we assess. So the first assessment is on the level of nicotine dependence. For example, we use the Fagerstrom test for nicotine dependence to look at their severity, because the scoring of the 6 questions would give us an idea what category the smoker is. Can be low, moderate, high, or very high level of dependence. So based on evidence-based practice, the clinical practice guidelines and the algorithm of treatment, then we choose the suitable, for example, nicotine replacement therapy based on the level of severity. Those who are highly dependent would require at least the highest dose of medications. For example, we know the NRT gums, they come in 2 milligram and 4 milligram per piece. So for those who are highly dependent, the 4 milligram gum is chosen over 2 milligram. And similarly, when we start patient on the nicotine patch, we will look at this level of nicotine dependence, and we personalize it by choosing the highest strength or the highest strength for the patients or smokers with the highest level of nicotine dependence based on the FTND. I also mentioned that we also consider the other factors like suitability, which in terms, in short, we consider their social environment, for example, occupation. So those who are considered frontliners, not necessarily healthcare frontliners, but people who work dealing with people like teachers or people working at counters publicly, so they cannot be chewing the gum as frequent as required. For example, they have to chew the gum every 1 to 2 hours initially. So those people who work at the front line, they cannot be chewing the gum. So they have to be given consideration for the NRT patch, for example, or the tablet varenicline. Currently, no. Last time, we used to have the nicotine inhaler. However, it's no longer marketed, so we only have these 2 dosage forms, i.e. the gums and the patches. I heard there will be another nicotine delivery product, but it's still in approval, waiting for approval. So we don't know whether we'll be having that as well. In other countries, there are other forms like the sprays or the mist. They also have lozenges, for example. These are all medications containing nicotine which have been studied and approved for smoking cessation purposes. Oh, okay. For the other non-nicotine-based product, I mentioned that we used to have varenicline under the brand name of Champix in Malaysia. However, recently has been pulled off the market due to contaminations of nitrosamines. So once that issue is resolved, then we hope that the medication will be back on shelves for pharmacists to dispense. So right now we're only left with the NRT. For the complementary or traditional or herbal products, we tested, actually, we previously studied Viva QS, a herbal product, but that's for research purposes for one of my master's students, and we found that it was it has good efficacy and also safety profile. But in order to get it approved, for example, for the use of smoking cessation, it would have to go under proper clinical trial, which is not done. However, in other countries, there are products called cytisine that has been produced and approved. For example, particularly in the Eastern European countries, which this plant actually been used for smoking cessation intervention. It's not approved yet or available in Malaysia, I don't think, but so you can only purchase it online. But right now we don't have it, so we're only using the approved medications in the form of NRT. For relapse, the first thing that we do is that we normalize the situation. For example, we tell them it's very normal for smokers to relapse. It's part of the disease process, i.e. the nicotine dependence from tobacco smoking in particular. So we tell them that smoking is a chronic relapsing addictive disease. So the component of relapse is part of the disease. So don't be discouraged. Many people would need many attempts before they can quit successfully. Studies have shown this can vary from 8 to 10 or even more attempts before they manage to quit. So at our clinic, we say, don't worry, we will still be here to help you. Let's set a quit date, a new quit date, and see what had worked, what did not work, why relapse happened. So we need to sort of analyze the root cause and try to prevent it from happening in the future attempts. Yes, studies have shown that when you get professional help, you can increase your chance of successful quitting even higher. For example, those who quit on their own without any help, their long-term success rate is less than 5%. Very low, less than 5%. Compared to that, with smokers who manage to get professional assistance, they can increase their success rate to more than 20%. We're not aiming 80% or 90% quit rate, because we're talking about nicotine dependence and addiction, which is, as you mentioned, very difficult to manage. But it's not impossible. I've seen my smokers who were able to quit with our assistance, but they also have to be, how do I say, motivated, and then adhere or comply to the treatment regimen, and they come for follow-up, and they are honest and truthful about issues regarding quitting smoking. Most people of this nature, they manage to quit, at least because they have a strong motivation. So at our clinic, we try to get their motivation on the onset, i.e. the reason for quitting. It can be health, it can be economy, it can be family and loved ones, many, many reasons. Recently, the high percentage of smokers registered to quit smoking because of COVID-19, realizing there is an association with increased risk of the infection and also complications and death from COVID-19 in smokers. So the motivation can change, it fluctuates, but here at the clinic or as providers of smoking cessation service, we are their treatment supporters, intra-treatment. And we also rely on their family, friends as extra treatment supporters. So a combination of using pharmacological intervention and also identifying the behavioral intervention that's suitable for them in order to increase their chances of successful quitting. Yes. To the smokers, my sincere plea is that make an attempt to quit smoking, even if you feel that it's difficult or you have attempted it before. Don't be discouraged. There, we can try other methods, other ways that you may have not tried before. We have updated evidence regarding how we can help smokers to quit successfully using the combination of behavior and also pharmacological interventions. Do register for www.jomquit.com in order to get more information and also assistance, and possibly you can get healthcare providers assistance to help you on your journey to quit smoking successfully for your health and also your wealth, your family members, your community, and the world at large. And to the non-smokers, do exert your rights to smoke-free air. We have the rights not to be exposed to second-hand smoke or third-hand smoke. And if you want to intervene, you can do it emphatically and politely, assertively, without hurting the feelings of the smokers. Although you may not, for example, agree with their behavior, but you have to understand that you are dealing with nicotine addicts who would go to any length to get their nicotine fix. So what we need to understand is that they are in need of help. So if you can help them, that would be great. But if not, you can refer and provide them with information, as I've said, from reliable sources, online and also offline. Encourage them and be their supporters. They are your loved ones, they are your friends, your brothers, or even sisters. This applies also to those who not only smoking, but also vaping. There's also another health issue that we have to deal with. So if you can refer to health professionals, that would be great. But you need to also exert your rights and report if you see people smoking at non-smoking or vaping places. There's numbers that you can call and WhatsApp so that the venues can be alerted that there are smokers, for example, smoking in their premises, for example, eating premises, which are now totally smoke-free unless you go 3 meters away, right? So we have our rights. There are more non-smokers anywhere in the world. Even in Malaysia, we have about 5 million smokers, and there are more than 30 million of us. So the majority are non-smokers. So we have to play our roles in advocating smoke-free environment and exert our rights as non-smokers to get fresh, clean air.